Welcome back to another episode of Coffee with Coker. My name's Mark Rybolt. I'm the host. I'm also a Senior Vice President at the Coker Group. And for those of you maybe tuning in for the first time or aren't familiar, Coffee with Coker is a healthcare business podcast, and we talk about issues and solutions helping healthcare organizations navigate the changing industry landscape. And so we have another episode today with a reoccurring guest that we've had a couple of previous episodes, and it's always an enjoy talking with this guest because he brings a great perspective. But our guest is Dr. Mac Knight, and he's Coker's Chief Medical Officer. And today what we're talking about actually is a follow-up to an earlier episode with Dr. Knight, where we talked about big picture value-based care, value-based healthcare models, and kind of this evolution towards more of a value-based care delivery system. And what we wanted to do is follow up with Dr. Knight and maybe take that discussion to the next level of detail, if you will, and start talking about how some of these models are, going into the marketplace today, and how organizations are actually embracing value-based care and value-based reimbursement. And so that's exactly what we're talking about today. The main topic is ValuePath. And what that is what we here at Coker have kind of termed our overall services that relate to value-based care, value-based reimbursement, and what we do with clients in that realm. And specifically, we're talking about transitioning to a value-based care delivery model, and some of the things we've seen working with clients and observing organizations out there in the marketplace as they are moving towards value-based care. And so we wanted to get some more perspective on what that can look like, because it is very much a new thing, and we're in the early stages of this evolution. And there are a lot of questions and a lot of discussion out there, even a lot of challenges for organizations that are just trying to figure out where to start going down this road, and ultimately how to make it work for their respective organizations. And that's exactly what we're talking about here. So I hope you enjoy. I hope these topics are relevant and meaningful for you all as you're thinking about this. Also, I want to continue to encourage all of you to listen to all of our episodes, which you can find online at the easiest place to find them is at coffeewithcoker.com. You can also find them on our main website, cokergroup.com. And we also want to encourage you all to submit feedback and questions. We want to make sure future episodes we're talking about things and topics that are relevant to you all. And so any ideas you have for a topic you'd like us to cover, or if you have specific questions you'd like us to respond to, we would love to do that. So please submit those questions. You can do it directly on the site or send us an email, feedback@cokergroup.com, and we'll make sure we respond to all of them. Again, we hope you enjoyed this episode, and we look forward to continuing this conversation on value-based care. Thanks for listening. All right. Well, welcome back to another episode. And again, we are joined by one of our, I guess what's becoming almost a reoccurring guest here on the podcast. But so we have once again with us Dr. Mac Knight. Welcome.
Thanks. Glad to be here.
Dr. Knight is the Chief Medical Officer here at Coker, and he is the kind of leader for us on all things value-based care, I would say, is probably a very broad, generic way to put it, but that is relevant in terms of what we're talking about today. Mac, as you know, what we're talking about today is what we call here ValuePath, and obviously we're going to talk more about that in detail, but really this is about transitioning to a value-based care delivery model. And whether you're a hospital, a health system, a medical group, value-based care, we obviously know it's here, it's coming, and it's, there's only going to be more to come as it relates to this topic. So it's very relevant, but I think it's also still very new. And so it makes a lot of sense for us to kind of dig in to what does it mean? What does it look like today versus, some ideas or indicators in terms of where we're going. if you all will recall, we had, I think it was episode 2, where we kind of did a broad scale introduction to value-based care, value-based reimbursement. And that was intended to be kind of high level, because I think that's helpful in terms of helping people understand what we mean when we talk about this. And then what we wanted to do is follow up and take some further time to dig a little deeper into what this is, what this means for providers and provider organizations. And so that's really what we're doing today, is kind of taking that discussion, I think, to the next layer, if you will. So, Mac, maybe if you will, and so we can lay a little bit of foundation or provide a little context, give us kind of the high level overview. When you talk about value-based care, what does that at a high level mean?
Sure, absolutely. So, Mark, if you think about value-based care delivery replacing volume-based care delivery, and again, we like to always say that that's not going to happen overnight, if ever, but certainly all the leading indicators are showing that the move to value-based care delivery in the system is happening and coming quickly. And I think, as we discussed in that episode 2, the most important factor to remember is, what are we talking about when we talk about value? So traditionally in healthcare, we have talked about volume of services. Those have been paid for on a fee-for-service basis primarily, and basically you provide a service, it's well defined, it usually has a code assigned to it, both diagnostic and procedure code. You submit an invoice and you get paid for providing that service. In a value-based care environment, you are essentially delivering value, which we simply define as quality per unit of cost. So if you think of that in a formulaic fashion, in the value equation, as we call it, value would equal quality over cost. And so the trick in value-based care delivery and value-based reimbursement is that you want to optimize, increase quality, and at the same time do that at a lower cost. So value-based care delivery, and again, I'm biased, but being a clinician, I think that you can change the payment models, you can change the incentives, you can change the organizational structure around this, but what really has to happen is the care delivery at the front lines of the delivery system, at what I like to call the bedside level or the exam room level or the operating room level, has to change so that the focus is not on how many procedures or services you can deliver per unit of time, but how much quality can you deliver and at the lower cost.
Mm-hmm. Two overarching key points, I think, there, that the fact that there are kind of there's a formulaic way of approaching it, but it doesn't have to be scary. I remember when the whole concept of pay for performance really started to be pushed, and quality was mostly linked to outcomes. That's what we were going to track, and EMRs were going to be kind of the key to moving us along down that road. And that was really scary, because that's a hard formula for us to comprehend. I think for clinicians, there are so many variables there, and it's also hard to quantify. But I think here what we're talking about is this is something that we can quantify, and it doesn't have to be something that not only will it not change the way care is provided in a negative way, but it really can be structured to reimburse in a reasonable way for how care should be provided. And frankly, usually is for most physicians, most clinicians out there. They're doing what they need to do, not always getting paid for it, basically.
I think that's a very good point. And I always like to say, trying to optimize quality and cost efficiency is really not anything new. I think physicians and healthcare providers of all types have always emphasized those two things. What I think is different is to actually get measured on those parameters and have that factored into the way that you're paid. But I really think at the heart of this is that most providers understand that the thing about healthcare delivery is not just a volume production system, but again, delivery of high quality and delivery at a reasonable cost. Most of us went into medicine not to see how many procedures we could do per day, not to see how many patients we could see per day, not to see how many people we could order tests on or imaging studies on. We went into medicine because we really wanted to help people, do that in a way that, didn't break the bank. And so I think this, at its essence, appeals to providers' original motivations, if you will, for going into healthcare. Is it going to take some getting used to? Absolutely. Old habits die hard, and doctors my age have been reimbursed on a fee-for-service, volume-based, fee-for-volume methodology for all of our professional lifetime. So it is going to take some changes, but I think it's changed for the good.
Yeah, I want to address that with the other kind of key overarching point identified. Before I do that, I want to just reiterate, and I mentioned this in the intro, but our discussion today, just so that everyone is aware, is really tied to, I know, a white paper that you've written, and you actually have a couple of white papers and a number of articles that you've written on specifically this topic. So I just want to reiterate that for people that are interested. That'll be available in the show notes, link to those resources and references here where if you want to find more information. But we are kind of following some of those points. But the other point I think there that's key to what you just said is the fact that this, and you said it earlier, this won't be something that happens overnight. And I think to kind of what you were just saying, this is something that requires change. It requires evolution to a certain extent. It requires some compromise from various stakeholders and parties that are going to be involved. And so, the healthcare industry has never been great, or at least they've never been quick as far as embracing change and that type of thing, which is okay. But I think it's a good reminder for us as we go into something like this, because in a world where we're used to things changing real quick, as long as we know this isn't going to happen overnight, then I think that's something that we know we're kind of on more of the marathon versus the sprint here, perhaps, then we know what we're working towards and maybe what to expect, and a little bit of ups and downs, back and forth, that type of thing. But what I want to talk about, or what this discussion really hones in on, is that whole process of transitioning to a value-based care model. So let's start with, what are some patterns that you think have changed today in terms of where we've gotten today from relatively early on in this evolution, like in the medical practice, for instance, or kind of the physician operations side of things? What do you think some of those patterns, how do you think some of those patterns have changed?
Well, it's exactly as you described. It's a transition. It's moving from one business model, if you will, one production model. I sometimes kind of shudder to use terms like that to apply to healthcare delivery, but we are in a business. We do produce services, and so those things are transitioning from a volume-based model to a value-based model. And what our ValuePath suite of services, as we call it here at Coker Group, does is it hones in on what actually has to happen in that transition. So if you're a physician group, if you're a hospital or healthcare system, if you're a post-acute care provider, and you're saying, okay, now I've traditionally been in a fee-for-service, volume-based business model, production model, and I know that with the advent of MACRA and MIPS and bundled payments and shared savings agreements and ACO models, et cetera, I'm going to have to move more towards a value-based production model. What do I specifically have to do to accomplish that? What are the steps that I have to go through to successfully operate, as I have for years in a fee-for-service model, in a fee-for-value model? Mm-hmm. And that's what we try to outline in the ValuePath suite of changes or services, if you will. It's a number of things. A lot of our clients, quite honestly, say, I know this is coming. I know it's inevitable. MACRA is going to be fully implemented as of January 2019, just a few months from now. But I don't really know where to start in terms of getting ready for this. I can certainly know that I'm going to get paid differently. I can certainly know that I've got things I have to report in order to get paid different than I used to. I certainly know that I've got opportunities to sign up for other types of business agreements, such as bundled payments. But when it comes to changing my care delivery system, again, whether it's a hospital or a physician practice or what have you, I don't really know where to start. And that's where we can come in and say, here's what you need to do. Here's a stepwise, systematic approach to this that'll get you from here to there safely, seamlessly, and with hopefully less disruption than just kind of waiting for it to come and not being prepared.
Yeah, there's a horrible analogy to use probably, but I think about that old cliche, how to eat the elephant. You gotta start somewhere and take it one bite at a time. But there probably is. I think the point here is there's a way to do it that's better than others. And the other kind of reality here is that I think when the discussion around what this could possibly look like started within the industry and kind of in those circles, I think there was an initial mindset that this was going to be kind of like meaningful use, and that meaningful use came out and it was essentially very set criteria. And you could really look at it like a checklist. And that's something that can be easily integrated into like a technology solution, or even just a kind of a simple, relatively minor change in the way you go about your practice on a day-to-day basis. This is much more systemic than that. This is not going to be a checklist. This is not going to be something that some magic solution is just going to be the silver bullet and take care of everything for you with the flip of a switch. It's a process. It's an evolution. And there are many different, or at least numerous different layers to it, which will probably continue to expand as the further or deeper we get into it. So I think that's an interesting distinction, because I think a little bit, and MACRA is a good example of, okay, that's something specific. That's going to be specific criteria, specific provision that goes into effect that will require compliance. Right. But that's only kind of the first step and one layer of what this could potentially look like. So I think that's interesting, because where we're at today, every organization out there is at a different point. Like you said, some are, just trying to figure out where to start or how to process it. Others are dipping their toe in the water a little bit. Maybe they're doing some risk-based contracting or, cost sharing or unique cost accounting arrangements, things like that. But what are your thoughts there in terms of key success factors for performance and really thinking about the whole evolution or this whole transition from where we are today to more than just dipping our toe in the water?
So I think you mentioned the magic word there, and it's a word that's actually anathema to many healthcare providers. and that's risk. The R word is something that a lot of healthcare providers run away from and say, I just have no tolerance for risk. But the truth of the matter is, the one thing that all these value-based reimbursements come with is increased risk. So again, we've always had the risk of clinical outcomes. As a provider, you take on that risk when you agree to care for people and try to produce the clinical outcomes that you desire. But the financial risk is something that, again, most providers just aren't comfortable with and don't know how to really manage. So what I think is a good starting point is to look at the risk inherent in the population of patients that you're responsible for and try to quantify that and try to understand that better so that you can focus on that risk and better manage that risk than you have in the past, especially the financial risk. How do you do that? Well, again, there is a methodology for this. It's been around for a while. Those of you that have practiced in a Medicare Advantage program know about this, but there is a risk classification methodology. It's called the RAF score, Risk Adjustment Factor Score. It's built out of things called hierarchical clinical conditions, or HCCs, and these are around 70-some clinical conditions that then map to over 9,000 diagnostic codes out of the ICD-10 methodology. But what you can do is you can capture these HCCs for your patient population. You can then use them to build up a RAF score for each of your patients, and that will tell you a couple of things. It will tell you where is the risk that you need to better manage in your patient population. The higher the RAF score, the better risk of that patient of both clinical deterioration over time and also expenditures or financial risk over time. So if you've got a population and you do this stratification by calculating their RAF scores, then you can say, okay, this top 25%, or you can use the old 80-20 rule, this top 20% is going to drive 80% of the cost and 80% of the clinical risk going forward. And then you can start to build care processes around that to better manage that risk. I will just say one last thing on the HCC capture and the RAF score development. The other thing that's happened since the bad old days or good old days, whatever you want to call them, I think they were probably bad old days of managed care in the 80s and 90s, which a lot of people compare to value-based care that we're under right now, is that technology has advanced significantly. So there is technology out there that you can use to historically generate HCCs and RAF scores for your patients. And we very, very much recommend that you use that kind of technology. In fact, we're teamed up with a company that has a system to look at claims data historically and develop that type of scoring. And again, then everything kind of stems off of that hierarchy of RAF scoring that allows you to focus your efforts where they're going to do the most good.
Yeah, I'm glad you mentioned that, because we're going to have a podcast episode in the future where we're going to drill down and look at a couple of those, at least some of the solutions that are out there and some of the ones that gauge how far along they are. But I think it's also, when you're talking about the technology, it's something that, and this is no dig at our EMR vendors out there by any means, but this is not necessarily your standard data that's going to be captured in an effective or efficient manner to do what you're talking about doing. This is kind of another layer of data mining, tracking, analytics, and ultimately one of the key, most important points of that is reporting on it. Reporting on it so that you can accurately measure risk and thus get paid on it from a value standpoint, value-based contracting standpoint, but also from a compliance standpoint, which I think is much needed. And it's something we're still I think they're figuring out, CMS is figuring out exactly how they're going to ultimately measure and track. But it's interesting, because when you talk about RAF scores, and you think about, at least in the hospital world, we've had HCAPs around for a while. We've had readmission, reimbursement incentives aligned to readmit rates, and now HCCs and the risk adjustment factor. I think this is something that a lot of your, at least hospitals, and I think a lot of your groups out there they probably aren't that unfamiliar with it in terms of the capability to do what you're talking about doing here. It's just been kind of whether it's getting over that, dealing with that realization on the risk, what you're talking about in terms of the impact, what risk means, and how that can be just challenging to grasp at a conceptual level and feel comfortable with it, or having the systems in place to be able to truly manage their revenue cycle process around something like this. Do you think that's right? I mean, is that something that most of your provider organizations out there are pretty close to being able to do?
I think so. I think there are organizations out there that are very familiar with this. They're mostly organizations or providers that have been in programs like Medicare Advantage, but going forward, I think everybody's going to have to get up to speed on this. And let me just give you a kind of a straightforward example of how that would work. So if I was an internist out there in private practice today, and I knew that MACRA is going to be fully implemented within the next 5 months, and I wanted to make sure that I was going to be in that top tier of providers under MACRA so that I could get an increase in my reimbursements as opposed to a decrease, I would definitely take a look at my Medicare patient population. I would use a system, and as you mentioned, there's several of them out there that could tell me, based on those historical claims data, what the RAF scores were for each of those Medicare patients. And then I would take that top, whatever you want to say, 20%, 30%, even 50% of that population who had high RAF scores, and I would reach out and I would start to do several things with that population that historically maybe I had never done. What would I do? First of all, I'd get them all in for an annual wellness visit. Medicare now pays for that. It doesn't even have to be done by a physician. It can be done by a non-physician provider. But it'll give you an extra revenue stream, and it gives you an opportunity to interface with that patient who's, because of their high RAF score, is at high risk and likely to have a number of chronic conditions that you're going to have to better manage over time in order to provide high-value care for that patient. So I would bring each of those patients in, do an annual wellness visit. If they had 2 or more chronic conditions, I would then shuttle them over to a chronic care management program, which is another new service that Medicare will reimburse you for. You don't even have to do that with face-to-face visits. You can do that telephonically. You can do that remotely through telehealth. But the concept is you talk to them on a monthly basis. You review their status. You adjust things. You care for them in a remote fashion. Doesn't have to be face-to-face. And you get reimbursed for that. And guess what? You're managing their risk more completely than you were before. And you're doing it, especially if you're doing it through telehealth methodologies or even just telephonically, you're doing it in a much more cost-effective fashion, so you are providing that higher value, lower cost care. So that's just a concrete example of what I would do if I was a provider out there today trying to say, well, what am I going to do different than I did in the old fee-for-service world? I would say, find out what the risk scores are for your patients and focus in on those that you know are highest risk to not only have complications and problems that you want to avoid for them, but also to generate more costs and expenditures for the system.
Yeah, I mean, one of the scenarios I've heard recently come up, there's a system that in their step-down care process, it was, I think it was post-acute, their post-acute process or rehab care maybe, but it was, kind of the policy was any issue over a certain level, and this was a very low par that was set here, goes back, automatically to the ER. Well, as you know, that's and goes into readmission from there. And as you know, that's from an efficiency standpoint, very complex or maybe unnecessary. From a cost standpoint, very costly. And frankly, from a quality of care standpoint, not the best solution.
Right. And
if you can mitigate that through, like you said, through whether it's something remote or telehealth, and being able to bypass that and really send them where they need to be, or just provide the care they need where they're at, as opposed to going through that whole thing. I mean, that's kind of a no-brainer. And so anyway, I think the RAF, going back to the RAF discussion, I think it's also interesting because you get to, I know there's some trepidation out there in terms of this concept of managing risk as opposed to managing patient care. And there's kind of a mindset, there can be a mindset issue there, or a conceptual issue, if you will. But I think that every provider out there know the two go hand in hand, and as long as there's an equitable way to connect them and measure them both at the same time, and I think RAF is kind of the at least the answer for now, at least one answer in terms of how we can do that. What are your thoughts on the whole, when you're talking about managing patient populations, my patients are sicker, that whole concept?
Well, it's interesting because when I try to talk to physicians about risk scoring using HCCs and RAF scores, I say, look, one of the advantages of this, one of the benefits, is that every doctor that I know does like to say, my patients are sicker than anybody else's. And this is your opportunity to prove that. So you can say all day long, my patients are more complicated, my patients have more complex illnesses, my patients have all these challenges that the guy across the street doesn't face in his patient population. But if you really want to prove that, go in and report their HCCs and develop their RAF scores, and that'll prove it for you. The other benefit to this is that there is competition out there in the payment world amongst physicians and other providers for differential pay based on performance. So if you want to fairly have your performance compared to somebody else in such a system as MACRA, then you've got to have a way of making sure you're comparing apples to apples, oranges to oranges, and not apples to oranges. And the system to do that is this risk adjustment factor scoring, so that, again, if I take care of a highly complex patient population and my quality score is X, and my colleague takes care of a much less complicated, much less challenging population, and his quality score is Y, then we can normalize those two and fairly compare them by using a risk adjustment factor. So I think it's something that, again, really is needed in the system. Is it perfect? Does it take into account all the factors that can make a difference in terms of population health management and care delivery? No, but it's certainly a good start.
Yeah. Continuing on talking about RAF scores and managing RAF, one of the points I know you made in your white paper and a presentation you did on this recently is that using RAF data and how to use that and optimizing it. And I think the importance there on using that data as a tool to prioritize and focus efforts where they need to be in greatest areas of need. And that ultimately ties to, obviously, patient care and improving quality, and also creating or enhancing value, of course. The two, they go hand in hand. But I think what's interesting, one of the points you made was it helps these organizations do this both at the point of care, at the practice level, and really throughout the entire organization, which gets to the whole care coordination and even a broader discussion around clinical integration. Maybe just talk about that and why that's relevant.
Yeah, so one of the challenges in terms of providing higher value care is to overcome the disintegration, the dysfunctional lack of coordination within the system, and try to improve that. And so if you are, again, focusing on that 20% that drives 80% of the clinical risk and the clinical costs, then what you need to do is not only say, okay, I'm going to get everybody in for an annual wellness visit, but let's say a chronic condition that's common in that population, such as heart failure or diabetes, I'm going to set up coordinated care pathways in the system so that those patients are better taken care of in a more seamless, coordinated, a well-choreographed best practice fashion. That's got to happen. Again, too many patients get lost in the system. They fall through the cracks. Their primary care doctor may be doing all they can in terms of, again, managing their heart failure, but they're not getting the referral, or if they do get the referral to the cardiologist isn't really syncing with what the primary care doctor is trying to do, and everything falls apart. So it's got to be a choreographed, well-coordinated system of care that, again, focuses in on those high-risk patients and those high-risk conditions that can really drive both bad outcomes and high costs.
Yeah. Talking about value-based care as a whole and kind of transitioning there and putting that in the context of managing RAF scores or improving RAF scores, how is that relevant, and why is that important to some of the other key areas of value-based care? Specifically, I know in your papers you've talked about clinical integration, care process design, value-based contracting, some of those operational performance, things like that. Just speak to kind of how this all ties back to some of those different elements of overarching value-based care?
So, and again, this is perhaps overstatement, and is really just used to kind of highlight the problem. But for years, what we've had in the healthcare system is an acute, episodic care delivery model that really focuses on, just as the name implies, acute problems as they arise in a very episodic manner. So, for my professional lifetime, I would sit there and wait for patients to access the healthcare delivery system. I'm not out there calling up the 20% that have the highest RAF score and saying, you need to come in here and get an annual wellness visit. No, I'm sitting there waiting until somebody gets sick and they call me up and say, I need to see the doctor. That has to change. We have to say we are now responsible for the care of this population. So we've got to be proactive in terms of contacting them, knowing who they are, knowing what their problems are, and knowing what their risks are so that we can better manage them. Second thing is that, again, in the current system, we do lots and lots and lots of what we do in silos, which are not well integrated with each other, and unfortunately vary tremendously from one silo to another. So the way that I manage diabetes over here may be very differently than the way the other primary care doctor over here manages diabetes. It may be very different, both of us, from the way the endocrinologist does it. And nobody's talking to anybody, and therefore you, depending on where you are in the system, you're getting all kinds of variation in care delivery, which result in variation in outcomes and patient satisfaction and all of that. Lastly, there is going to be, and already is, a demand for, as we talked about a minute ago, more coordination of care so that the expensive duplication of services within the system and other elements of waste can be driven out. So again, I'm a hospitalist by training. Many is a night that I've admitted a patient to the hospital. Their story is, I saw my primary care doctor 2 days ago. I had this and this symptom. He or she put me on this and this medication. Oh, by the way, they did this and these tests. I don't have any access to that, so what do? I repeat all those tests, or at least what I think they probably had. I prescribe even more medications, not knowing what they've already been on. What does that create? That creates waste and inefficiency. It drives up cost, and it can be very, very risky to practice medicine like that. So that there has to be ways to coordinate that care across the system, so the hospitalist knows what the primary care doctor is doing, the surgeon knows what the referring physicians are doing, the specialists know what the primary care doctors are doing, and everybody's operating off the same page.
Yeah.
That's the kind of things that I think a value-based care delivery system really needs to achieve in order to meet the demands of the future.
Yeah, I think it's interesting. I encounter a lot of management teams, whether it's on the hospital side or on the group side, physician practice side, that will tell you, listen, we're down the path on clinical integration. We're clinically integrated, and it's not that they're not. But I think you can kind of look, as you get in, look a little deeper at the actual case, the actual situation at hand. You realize, okay, there are a lot of gaps there that suggest there are some not only missing pieces, but key missing pieces. And I think that care process piece is one of the most important, Because I think first, we've already seen a lot of the hospital and physician alignment. So kind of that first step towards integration, but that was just ultimately consolidation, right? That was coming together. And of course, we're still seeing it. And many transactions of that nature continue to happen every day, which is great, but that's not integration. Okay, well, what's the next layer? Well, there's the information, the data, and all of that is coming, and then we're starting to integrate service lines and departments and those types of things. And so I think they are moving through it. That care process design piece, I think, has to be there as a critical element in terms of really achieving any sort of clinical integration and doing what you're talking about. And then there has to be the back end support systems personnel that help facilitate that. And that gets into value-based contracting and reimbursement. That gets into revenue cycle management. That gets, essentially everything to make sure the whole picture really works.
Yeah, I like to separate what I call vertical integration, which is the historical trend that we've had in the last 2 or 3 decades of wide-scale employment by hospitals. And vertical integration really was mostly a way to steer referrals from primary care up the ladder to specialty care, to tertiary care, to inpatient care, and to make sure that that referral process was integrated. What we have today is what I call horizontal integration. So now you've got the same players, but they're coming together, and they're really coming together to coordinate care around or horizontally around the patient, and to ensure that, again, it's not a matter of driving referrals, it's a matter of improving outcomes, both quality of care outcomes and cost outcomes.
Yeah, I think that's a good way to look at it, because you're right. We have seen that vertical integration, certainly, and the horizontal integration is coming, I guess. It's evolving, and maybe the ultimate solution is some sort of spherical integration or circular integration, right, like you said, around the patient at the core. So I think that's a good way to look at it.
I think what's interesting too, just as an aside, is that the horizontal integration really, again, utilized employment models in PSA models and other things that we deal with a lot in our consulting practice, whereas horizontal integration, clinical integration, doesn't necessarily rely on those same sort of alignment strategies. Horizontal or clinical integration can occur without employment. It can occur without contracts. It is simply a banding together of providers in agreement to focus on high-quality, low-cost care delivery, and again, is talk about risk, much less risky for the health system, for instance, than having the stress of hundreds of employed doctors on their balance sheet. So,
yeah, good point. Well, this has been really helpful. One of the things I think, we kind of make it a general rule here for the podcast that the point isn't to come on and talk about Coker services ad nauseum, but I do think it's interesting to tie in some of the things we do into the things that we're talking about that are ultimately relevant to the market and our audience, our clients, and the organizations that are out there in the market. So with that, you mentioned earlier this concept of ValuePath. And I think it would be helpful, if for no other reason, just to briefly go through, kind of talk about, because we are talking about transitioning to value-based care and working through that process, regardless of where you are in the process, I guess. So maybe just talk about that the model, the ValuePath model, and kind of the tiered approach that we take there, and how that may be relevant to any organization that is trying to ultimately deal with this scenario.
Sure, and very much appreciate the opportunity to talk about that, because it is something that over the years I think we've studied significantly and tried to build to definitely try to meet the needs of where different clients and different types of organizations in the healthcare system are in this transition from volume to value. So it basically boils down to 3 tiers of the ValuePath program. Tier 1 is really just an assessment. What we do is we come in, we use the technology that I described to look at your patient population to determine the risk that you're facing. Is that population a Medicare population that's elderly and has a lot of chronic disease, and is it significant risk, or is that population a more younger, commercially insured, healthier population with less risk? We can, quantify that for you through this HCC risk adjustment factor scoring. And then once you know what risks are inherent in your patient population, we can then say, okay, here's a plan that you can accept or not accept to help you better manage that population going forward in a value-based reimbursement world. Second tier would be to go in and really just focus on some areas within that patient population that would give you quote-unquote quick wins. So again, using a somewhat tired term, you can't boil the ocean. You've got to start small and kind of grow from there. We would say, okay, here's your 20% of really high-risk patients. Let's get them in. Let's do annual wellness visits. Let's take the ones that need it and put them in chronic care management programs. We can help you design those. We can help you staff those. We can help you know how to bill for those. We can help you put the technology in place that helps you operate those, etc. And then the third tier is the organization that says, okay, maybe we've been through tier 1 and tier 2, or maybe we're even at a stage now, just from kind of natural evolution in the market that we're in, that we need to go for the full Monty. We need the full value-based care delivery system. So we want to embed across our system care process design, where we know that we're measuring on a regular basis off of our evidence-based best practice design care processes. What is our quality outcomes? What are our costs in those care processes? And we're constantly, through an iterative process, endeavoring to improve those processes so that we bring higher and higher value to our patient population. We're going to be so confident in our care delivery system in that kind of a model that we can approach payers before they even approach us. And we can attempt to be first to market with true value-based care delivery so as to capture the greatest market share of value-based contracting. So we're going to go out and seek out bundled payment agreements. We're going to seek out shared savings agreements. We might even, dare I say, sign up for capitated care management models such as Medicare Advantage, etc. Those are the kind of organizations that, again, want to jump in this with 2 feet. We understand that most are not there yet, but we've got a tier, either 1, 2, or 3, that can suit wherever you are along
Yeah,
along that transition.
And ultimately tailor it from there, because obviously
Exactly.
each organization is going to be different. And
Yep.
there are different things you can do versus what you can't. And there are different things, even within the can do column, there's things you can do today versus, hey, maybe we need to do this at some point in the future.
Exactly.
So that's helpful. I think that's good to provide that kind of background or context, because if we're talking about really transitioning, we have to find a model that helps us ultimately get there, a roadmap or something. I think that's what we're talking about here. So this has been really helpful. I appreciate it. Again, for everyone, we have some supporting kind of materials, white papers, and presentations that Dr. Knight has generated on this topic. So we'll make sure those are available. And again, we'll be having some even more follow-up discussion on this topic. Like we said, we'll probably get in, talk about some of the technology solutions that are out there, some of the other factors that are a little more granular in nature, but are obviously going to be relevant for organizations trying to move down this path. So we'll look forward to having those conversations. But thank you, Dr. Knight, for coming on yet again, and we'll look forward to having you on the next one.
Thank you for having me, and always enjoy it.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.